So I'd like to invite now Dr. Simon Sutcliffe, who's going to moderate the final session of the workshop, trying to close the loop on everything we've discussed over the past 2 days. And he's presenting virtually, so I'll invite him to the virtual podium.
Thank you very much, Tarek. So welcome to this panel discussion. The topic is how can we help reduce the burden of cancer in low and middle income countries? Something that's of relevance and importance to the Canadian Global Cancer Network and to all who are interested in global health. How can we help reduce the burden? Reducing the burden, as we've heard over the last 2 days, is more than having a strategic plan or statements of intended compliance with global resolutions. An effective response is contingent upon a strong resolve to implement activities to protect and maintain health and save lives that would otherwise be limited by disease. Yesterday, in session 1, we heard from 3 organizations engaged in global cancer control with partners in both high and lesser resource settings. Whilst presenting who they are and what they do, each stressed the importance of how they do it, the circumstances that determine whether collaborations are likely to achieve sustainable partnerships to address cancer control at a population level. Our discussion today will bring continuing focus to how collectively we can establish the conditions to advance cancer control for populations experiencing inequitable care. Our distinguished panelists will be Her Excellency Dr. Zainab Bagudu of Medicaid Cancer Foundation. She is the First Lady of Kebbi State, Nigeria, a consultant pediatrician, a global cancer advocate, a champion of women and children, and with a particular reference to cancer control. She is a board member of UICC. She will be joined by Dr. Susannah Stanway, consultant medical oncologist, with a career focus on breast cancer, survivorship, especially cardio-oncology, and cancer control in low and middle income countries. Susannah has been an active participant in London Global Cancer Week and the UK Global Cancer Network. Dr. Antoine Loutfi, a past member of the Departments of Surgery and Oncology at McGill University with professional career activities in Ethiopia, Rwanda, Uganda, and the Democratic Republic of the Congo, cannot be present for personal health reasons, but I will bring his comments into the discussion as we proceed. And I would welcome our panelists to view this as a conversation and a discussion in which we can all participate, and welcome any questions from the audience, which would be helped by Arjuri and Tarek in Montreal. So perhaps I could start with a general question. How would you characterize the major barriers to reducing the burden of cancer in low and middle income countries? And how do you think they could be approached through collaboration with a higher resource partner? Perhaps, Dr. Zainab, I could ask you if you could commence the discussion.
Hello, good evening, everyone. Thank you for the invitation. Well, in low middle income countries, and speaking from my own perspective in Nigeria, which is the largest country in Africa, there are many issues that affect improving cancer control. I think number one on the list from my own experience is the awareness. Awareness is for education and knowledge of people about cancer in general, about most diseases, but then about cancer is even worse. There's also a lack of systemic response to the condition. By that, I mean the health system is weak and screening is almost not very routine in my part. There are some African countries and some other low middle income countries that have been able to institute better or good screening mechanisms in the countries. But for us, it's still not yet existent. And then with I will mention funding at this point, because with funding comes the issue of appropriate research, appropriate responses, treatment, access to care, and all the difficulties that people that live in hard-to-reach areas from immunization right up to palliative care face. We do have a national cancer control program, but in my state, we have a state one as well, which I would dare say is better funded than the national one due to the element of cost that is required to do the national, to do everything at a national level. So I think these three things are really most of the problems that we face in a low middle income country perspective.
Thank you, Zainab. And Susannah, perhaps I could ask you to follow into that conversation, and I'm going to circle back and say, so what have we heard and what do we know about what lower and middle income countries would really like to have? How can they approach us? How can they express what it is that we might be able to respond to?
So I think I would start by saying that I don't profess in any way to be a global health expert. I have an interest in it. There was a wonderful blog that was written recently about how not to become a global health expert. And I think that part of this whole narrative is making sure that the correct voices are heard and that people with lived experience that have common sense in these settings are heard. High-income countries are only 16% of the world's population, so we need to bear in mind that we're talking here about the bulk of the world's population, and that there's huge regional variations. We can't lump LMICs into one group, and that there's a scope of challenges. I think one of the barriers is creating a world where people care about others. Why should we care about people that live far away? And I think that part of that, I think that it should be embedded as healthcare professionals in our training. And certainly in our local training, I've set up a global oncology afternoon for trainee oncologists. I think we need political will. I'm not going to dwell too much on independent markets or on global debt, which is at an all-time high of 322% of global GDP. But I think, as Satish Gopal very eloquently said in his letter to the New England Journal of Medicine in 2016, what ultimately transformed HIV from an existential health threat to a prototypical global health success story was not just research, but it was broad civil society activism and political will. And these decisions need to be made within individual countries. Aid is not going to be the answer. But I think the story needs to be sold to the finance ministers that this is it's an investment, not a cost. And I think that high-income countries have got a role to develop that knowledge. Much of which is already out there. I think that there needs to be development of infrastructure. There needs to be development of cancer intelligence. Cancer control plans. We heard very eloquently yesterday from Karen Homan about the international cancer control partnerships. I think that there needs to be that we as high-income countries can contribute to education, both to the public and also of healthcare professionals. And we can also contribute to the research piece such that the research that's developed is contextually sensitive and is useful, as opposed to just transposing what we have from high-income countries. And also, as we heard from Bishal, about treatment minimization studies, much of which has to date been done in high-income countries, shorter durations of trastuzumab, for example. And we heard about the study of metronomic chemotherapy and lower doses of immunotherapy that's recently been conducted in head and neck studies, so important. And also access. And we heard from Gilberto about the ATOM coalition, and there needs to be better access to treatments that we know save lives and contribute to relieving suffering, such as radiotherapy and systemic therapies. And just to finish that piece, Miriam Matubi, who's a surgeon in Kenya, wrote a wonderful editorial to our two pieces in the Lancet Oncology last year. So the Canadians wrote about their network. We wrote about our global oncology network in the UK. And she said that this is about harnessing collective knowledge to innovate for collective good. And I like that as a concept.
Thank you, Susannah. And I'm just going to add in Antoine's comments to me. He felt it was really important to understand what lower and middle income countries really want, and to recognize fully the local context that only they can express to actually satisfy what they want. And he was very insistent on ensuring that there is that respect of understanding how you help the partner, not how you impose what you might think to be the right solution in another country. And that is an important concept. The ownership of the change that one wants to see is not owned by the high resource country, it's owned by the partner who in the country of grant. But I'm going to go back to Zainab and ask, so Zainab, if you were asking the Canadian Global Cancer Network, if you approached them and you said, in Nigeria, it would be really good if you could help us. This is what you really could do, and we could work on this together. How would you answer that question?
Well, I think issues like that I mentioned about awareness and education for the general population can best be handled by people that are used to the environment and living here. But however, there is a great need to equip those people. And so one of my first asks to the Canadian network would be to help with capacity building of the healthcare professionals. There's a lot of innovation available now. There's digital technology, and transmission of knowledge can be easily achieved through these means. So by partnering with local institutions in low middle income countries and helping to build the capacity of the healthcare workers, not just the professionals, from the community health extension workers who do a great deal of work in our communities, that would be one area. I'd also be keen to see exchange of research and inclusion of people from low middle income countries, particularly Black Africa, in the studies that are going on. I was reading a piece today that put together all the numbers of researches that had been in oncology over the last, I think, 2020. And of over 2,000 studies, only 15 were on Black Africans, whereas the bulk of the disease, over 60%, will occur in this group cohort, and we don't have adequate studies and inclusion from these areas. So that's one area where certainly it would be very easy to have the network work together with our own academic institutions, strengthening the processes and strengthening the knowledge that the healthcare professionals work. I think those would be what I would focus on for now.
Thanks, Zainab. And let me change the question a little bit for you, Susannah, because you're obviously in the UK Global Cancer Network. That's a high resource country network of potential collaborators. What would you be looking to hear from someone who approached you about helping them? How would you decide this could be a good fit, this could be right for us?
Well, I think first of all, you have to listen to what they want and see if you're going to be able to help them achieve that. I think that you need to have humility, that you don't know the contextual situation like they do, but you'll do your best to help. And I think that you have to remember all of the good things that all of the ingredients that come from good collaborations. You know, make sure that your roles are clear, that it's going to be sustainable, that there's a clear shared vision, a long-term view, transparency, you know, mutual respect and trust, that there's curiosity, that you're both open to reciprocal learning, coordination, that projects are not transposed from high-income countries to low-income countries, that there's no hierarchy, you know, there's no role for hegemony here. It's flat structures. And really where I think you can make a difference, but I think it's got to be driven by your partner. So what do they want? And do you think that you're going to be able to deliver that? Do you think that you've got the resources and the know-how to be able to help? So the UK Global Cancer Network, we're really focusing on bringing people together within the UK who are doing these kind of collaborative projects, such that there's not duplication, replication, and so that we can learn from each other. And yeah, find out how we can be of value, how we can help. But it's 100% got to be driven and led, or at least co-led, by the low and middle income country partners.
Thanks, Susannah. Again, I'm just going to introduce a comment from Antoine, who has worked in a number of countries in Africa. And his comment was, in building capacity, it's very important to build on what they already have in place, and not to come in with one's ideas about what should be in place, but to build on what is actually working in the local country. Susannah, You characterized a number of characteristics of partners that you think are good. Zainab, you'll have heard those characteristics. In your experience of working with partners, both within your country and between countries, what have you found to be the key things that determine you can really work well with these people? What distinguishes a really good partner from people who are here to help you and have the knowledge about the content matter that you're interested in?
Well, it is important to build country-level partnerships that are strategic and sensitive to the local resources. Local resources in terms of the human capacity, in terms of the financial ability of the country or the organization, and perception of the communities and the people to the diseases that we're talking about. It's important that the partners always sit with the local health leaders and the policymakers so that they understand exactly what we're trying to do. There's usually a broad understanding, but sometimes the way that partners come in can be structured in a way in a context of a high income country. Let me put it that way. There are lots of due diligence that sometimes go on that can delay the processes from happening or the particular intervention that we want from happening. When we had COVID, there were a lot of interventions and supports that came from high income countries to low income countries. But this was very fast without the usual bottlenecks and bureaucracies that can come with partnerships. Some high investments, for instance, radiotherapies that are being introduced by radiotherapy LINAC machines that are being introduced by some programs under, say, IAEA and so on. There are quite a few going on. They take a very long time because of these processes that they have to go through. But with a situation like COVID, we saw that we can definitely hasten that. So bringing the local stakeholders, the leaders, the policymakers, legislature, we've been talking a lot about parliamentarians and the need to involve them more. And aside from that, having it step down, having conversations with the actual subjects that are going to be involved in implementing the programs is very important. So conversations and listening to the people that matter. Then there also tends to be with a lot of partnerships and donor funding, what I see as a little bit wasteful spending. There's a lot of the commitments that goes towards things like providing, say, amenities for the partners that are coming into the country and making it easier for them to fly around. There are some organizations that will not go to some areas unless it's on a hired private jet. And you can imagine the amount of resources that takes off the funding itself. With other measures, it can be greatly reduced. So listening and, having an understanding of the local environments that we're working in and involving the local stakeholders earlier on. I'll also mention the issue of incentives. Sometimes work plans do not include incentives for the healthcare workers, despite all this big spending that is going on. And that tends to lead to failure because we're asking them to do a new program that is different from what their original job description says. And it can be met with some resistance, and it doesn't flow as well as it should be. So I really would like to see some incentivization of our interventions, particularly in cancer control, to the donor-led funding and interventions.
Thanks, Zainab. Susannah, I'm sure you agree with much of what has been said, but are there things that you would like to add in that you have seen as things that are critical in relationships, things that determine good partners working in a shared way?
I think that, yeah, the concept of listening to your partners is really, really important. I guess I'm speaking at a Canadian conference, so I rather like Jordan Peterson's in his 12 rules for life, number 9. Assume the person you are listening to might know something you don't. I like that. Humility, we've already mentioned, and understanding colonial history where in the countries where that's appropriate, I think is also really important. Having an understanding of that, but otherwise, no, I agree with what Her Excellency's already said. Yeah.
So let's talk about models of how collaboration could take place. You know, we sort of come from a history of interested and motivated groups working together in, for example, palliative care, radiation therapy, or perhaps medical oncology. But I think what we've heard is one should be striving to actually get to the whole cancer control spectrum if you actually want to change. It's system change one's looking for, rather than peaks and troughs of expertise in aspects of the cancer spectrum. So, Zainab, do you have a sense of what's a good model here? Does one invite lots of different groups to participate across the spectrum and hope to try and coordinate it? Does one try and twin with another organization? Is that a better model? Do you have a view on that?
Yes, I prefer the concept of twinning with an organization that has a good length of experience in a particular topic that we're talking about. For instance, if it's cervical cancer elimination, there are civil society-led initiatives that are already partnering with different organizations, the government, and so on, like we do. But when you have too many cooks at the table, it always spoils the eventual meal. So it's good to have stakeholders in the conversations, but when it comes to implementation, there should be leadership and there should be ownership by the local partners. And this can only happen if we have in-country champions that have enough experience in that particular area. They might not have all the resources that it takes, but they usually, or should I say, we usually have the experience that is required, and that can be built upon with what the partners are bringing in. And this is what a partnership and effective collaboration would be about. So I would go for the twinning option more, as opposed to having too many partners. Each organization can have its own umbrella of feed of different partners, but when we come to the actual work, there should be one clear leader.
Susannah, do you have thoughts on that, reflecting, for example, on the UK network?
Yes, I mean, I think that there are probably different levels of looking at it. So there are clearly the high level collaborations, and organizations like the UN agencies that have responsibilities for informing policy and guidelines, resolutions, convening, amplifying the narrative, etc. But I think that when it comes to networks that perhaps involve, speaking for myself, jobbing oncologists like me, I think that there's a role for contributing to things like education. So helping, working with people in low and middle income countries in education sort of platforms that they design, like Train the Trainer. But I think it has to be led by the partners because they know the context, but you can certainly contribute to that. I think the multidisciplinarity of the cancer care continuum means that sometimes high income countries, we've got a role in providing experts in areas like social sciences, anthropology for research studies that may not be available in a small country. I think that there's a role for us to contribute to research. And I think that there's also a role, certainly one of the things that we're exploring in the UK Global Cancer Network is involving the diaspora in the UK. And there's quite an active group of Nigerian oncologists, for example, that are keen to work with colleagues on the ground back home and other oncologists here. I think there's a role for mentorship and for remote support of initiatives like MDTs and remote radiotherapy planning, etc. And I think also that there's a role for amplifying the role, the voice of women in these countries. And that's another thing that Miriam Matubi brought up in her editorial. because women deliver so much of the care in these countries. And also amplifying the patient voice in these countries. I think that also needs to be done. So I think that there's those two levels. There's the high level, and then there's the kind of collaborations that we as job oncologists can do, and perhaps involve our institutions in twinning exercises like has just been illustrated. Yeah.
So I'm going to just pick up two things now that I'd like you both to reflect on. One is, should there be a term of relationships in a collaboration, or is a more open-ended, longer-term relationship a more desirable one? And after that, I'll come to the question of funding. Is it enough to come with in-kind goodwill, or is there more that's necessary if a partnership is really going to do something? Perhaps Zainab, but maybe you'd like to lead off on that.
So funding does not mean that you have all the answers. We have to keep on emphasizing the role that listening to each other talking can help, what that can achieve. And it's important that when the funding is put in place, everyone is clear and understands what it's for. There should also be involvement of the or some leverage of the political will and attention on where it is actually present and where there's a great political will to have things happen. The terms of projects should not be open-ended. We cannot continue to live on handouts or live on even good subventions from other countries. There should be a mechanism by which we transfer and transmit all our interventions into local ownership. It cannot be open-ended. There's absolutely no way that we're going to have non-stop support. There should be pilot studies as well, which is something that we didn't mention. If we think that partnerships or interventions are going to work, then it's important to have a small pilot study, no matter how small, how it works. We've seen quite a few going on in Nigeria now with the cervical cancer elimination. The success program started with a small 3 states, and gradually it's expanding to include all the other 36 states of Nigeria. And exactly what I was saying, the funds came, but the governments are also encouraged to add their own counterpart funding. And we've seen that happening in my state, so that the numbers of people reached can be more and more beneficial to our people.
Susannah, your thoughts on that?
Yeah, I mean, I 100% agree about the fact that it shouldn't be forever, and it definitely should culminate in local ownership. It should be local ownership from the beginning. But I think that having long-term relationships with people, as opposed to just helicoptering in and doing something and then leaving, I'm not in agreement with that either, because I think more can come out of long-term relationships. Yes, funding. I think probably we need to have some novel funding mechanisms for these kind of research endeavours. I think that there needs to be built-in sustainability. And I think that there needs to be an acknowledgement, as we saw from Dr. Pramesh, about the high patient to doctor ratios and how busy people are in low and middle income countries with respect to clinical work, and that they may have less time for research commitments. There needs to be acknowledgement of that. I don't know how it'll work, but maybe enabling of some kind of protected time, but definitely including people. They need to be included more on authorship lists, and there just needs to be more research generated from low and middle income countries that's relevant to them.
An interesting point you raise about the sort of hygiene of collaboration in your meetings, the time that's convenient for you, recognizing it may be highly inconvenient in another country, and recognizing that necessity to be a good partner. I notice now I'm just going to invite Arjuri and Tarek, if there are any questions from the floor that people would like to add in. We have about 5 minutes left in the conversation, and I'd like it to be a very open conversation. So, Arjuri, could I see if there are any comments?
Any questions from the audience? Tarek is waving his microphone around.
Question from...
We have one down below. I'll try to read it. Or Tarek, can you try to read it?
So
Yep.
from the chat,
Her Excellency Dr. Zainab has raised two very important issues that are very key to the development of cancer care in LMICs, which are the engagement of parliamentarians and incentivization. I'm not sure if there's any more to the question. And the question of incentivization is an interesting one, particularly in the context if one is doing clinical research that in some way is bound by ethical considerations. And the question of, so how does incentivization work under those circumstances? And that was a good point that was brought up earlier in the meeting today. But I think there is no doubt that people are not going to come to screening programs or early detection programs unless they can see the reason why they're doing so. And to lose time from work, to lose income, to travel, etc., without actually seeing something that makes a material contribution to their well-being is a challenge and needs to be recognized. Zainab, do you have any comment on that?
Well, I talk about incentives in context of the workers mostly, and not the communities that we want to bring to the screening program. When you empower the healthcare workers, they know how to, they are in direct contact with the community, and they put more effort and passion into it. The incentives in terms for research can be inclusion in the author list that Susannah mentioned. A lot of researches go on where the people that do all the work are not even acknowledged, and you just have the highly qualified academicians mentioned in the Lancet and so on. But we need to have ways to include our local scientists as well and create opportunities for them whereby they can also have their own smaller studies that might lead up to the big one. But for incentivizing the communities, no, I'm not a big fan of that. Sometimes we have to do it, giving out, toiletries and things like that. Sometimes it brings you bigger numbers, but it's really not the way to go. We should focus more on the education and making them understand the impact that these programs, the screening, the treatment, and all the things that we're doing is going to have on their health eventually.
Yes. Susannah, any comment on that you'd like to make?
And I think as things improve, you'll create survivors who will become advocates, and the circle will be completed, and then people will realize that actually going for screening or going to hospital for treatment is of benefit.
Interestingly, incentivization of healthcare professionals across the spectrum of professions has, in my experience, been a challenging one working with the diaspora who are now living in a high-resource country. There is often an insensitivity to what a local professional will need and tending to minimize that as being, well, they're already being paid, and we'd like our money to go to something very tangible that we can see for patient benefit. And that's a conversation that really needs to be handled, because if you don't have the healthcare workers, there isn't going to be anything in the product that you're working for or with. Marjorie, any further questions from the floor?
Any other questions? No. No more questions.
Susannah, Zainab, do you have any questions that you'd like to ask each other or myself or anybody in the room?
No, I don't. We just look forward to welcoming the Canadian network with the Nigerian network and the UK Global Cancer Network. I'd like to see a good collaboration there.
We're working on it.
Yeah, good.
I think what the event brought for all of us are wonderful new networks, partnerships.
Yeah.
It's very much a global community that came together to help showcase this event, to help circulate it, to help really push that registration, because we had hundreds of people who had registered from all around the world. And that's because of everybody's generosity in terms of sharing the event and reaching out to one another to welcome them and to come and say, hey, please come consider presenting at the event. So with that, I really, on behalf of the McGill Global Oncology Program and our greater Canadian Global Cancer Network, we wish to thank you, our funders, our speakers, our guests, who really came from all around the world to help fund, organize, attend, and participate in the event. A global hybrid event of like this requires careful attention, commitment, and follow through to be able to showcase an event such as this. And so it also required on that reliance of our global network, who were very much open, eager to share their time, their knowledge, and their networks. So we're most grateful to all of you, and I know I'm repeating myself, but we are most grateful to all of you for coming together the last 2 days to help raise awareness, exchange, and cultivate these new partnerships, which we all together hope to improve the cancer care for all. So I wish you all a wonderful evening, a good morning, perhaps to people who are on the other end on Saturday morning, but we thank you all very much for coming together. Thanks.